All right, you are now on.
Okay, great. Let me just share my screen. All right, good morning, everyone. My name is Kara Harville. I am a third-year family medicine resident at Swedish Cherry Hill.
I'm Neha Bakai. I'm a third-year resident also at Swedish Cherry Hill. My clinic is at Carolyn Downs, and we're so excited to be with you this morning. We are going to talk about, the title of our talk is Beyond Screening, Trauma-Informed Approaches to Intimate Partner Violence.
Right, and we wanted to just start off by clarifying a few of the words we're going to be using. Wherever possible, we're going to use the word intimate or the term intimate partner violence rather than domestic violence, but there are still a lot of organizations that use the term domestic violence, and a lot of studies also still use that term, so occasionally we'll be going back and forth between those two. Also, there's been a shift sort of generally away from the term victim and towards the term survivor. So wherever possible, we're also going to be using that term to sort of highlight the resiliency of the folks who experience intimate partner violence. Finally, for the most part, we'll be using the word patient since that is used generally when talking about folks who seek medical care. But at my clinic, the Seattle Indian Health Board, we use the word relative a lot to talk about patients to highlight the way in which we care for them. So occasionally we'll be slipping back into that as well. And then finally, we will be using terms like Native, Indigenous, and where appropriate, Urban Indian, and those are all somewhat synonymous. Finally, we want to just call out the fact that the majority of data and the majority of services are really geared towards cisgendered women. And so we will be talking about that primarily. We know, however, that multiple people experience intimate partner violence, and just given our time constraints and the available data, we won't be able to address all of that today. One thing we are going to do, though, is kind of highlight and bring to the fore the experience of Native women because they are so often omitted from the data. So we'll be doing that today. And finally, this is a really hard topic, really intense, and we want to just make sure that everyone who's listening takes good care of themselves. Please step away if this is too triggering for you. Our slides will be available if it's something you want to revisit on your own time in the future.
Okay, so the objectives of our talk. We hope by the end of the presentation, you will be able to define intimate partner violence and learn about its prevalence, describe the principles of trauma-informed care in relation to IPV, initiate conversation about IPV with patients. We'll highlight two different methods, and assist someone who is experiencing IPV with basic safety planning in your clinic or in the hospital, and learn how to access local and national resources for IPV survivors. Okay, so what is the definition of intimate partner violence? It is a pattern of assaultive and coercive behaviors that may include physical injury, psychological abuse, sexual assault, progressive isolation, stalking, deprivation, intimidation, and threats. These behaviors are perpetrated by someone who is, was, or wishes to be involved in an intimate or dating relationship with an adult or adolescent, and are aimed at establishing control by one partner over the other. And that last phrase, the control aspect, is really the central tenet to intimate partner violence, and it can take many forms. This wheel is helpful to depict all of the aspects of intimate partner violence and unhealthy relationships, the central tenet being power and control of one over the other. And on the outside of the spokes are like the most easily depicted signs of the violence, so physical violence or sexual violence. But inside the wheel, there's all these different more nuanced ways that intimate partner violence can manifest, and you can see how diverse the experiences can be of somebody that's experiencing intimate partner violence. Okay, so moving to epidemiology, This is so common. In the US, about 1 in 3 women and nearly 1 in 6 men have experienced some form of intimate partner violence during their lifetime. This is also likely vastly underreported, just given how sensitive this topic is. We know that also during COVID with the pandemic, these rates have increased, just given the isolation that people are experiencing. These rates are likely higher in our LGBTQ population, although there have been limited studies looking at this population. And looking by race, we know that our multiracial non-Hispanic and Black non-Hispanic women, as well as our Native women, report the highest rates of IPV. And this is a very, very relevant issue to our patient population in both of our clinics. Okay, so why are we even talking about this? What is the impact that domestic violence or intimate partner violence can have on health? We know that there's both acute and chronic health consequences of experiencing IPV in the short term, right? Like actual injury, bruises, fractures, homicide, suicide, and then longer term, chronic pain, PTSD, depression, chronic GI disorders, asthma, any inflammatory condition. And I think we also know that substance use is more likely in this population, that it increases risk of poor pregnancy and birth outcomes for our prenatal population. And a lot of times the consequences are so common that we forget that this could be a cause of what we're seeing in our clinic. This also has huge healthcare cost consequences, like looking at a systems view, causing increased healthcare utilization and just medical cost.
All right. So we wanted to take a look at the recommendation of screening. Prior to doing our research, we did not realize this was a controversial topic, but indeed it is. So we wanted to just highlight who recommends screening. So the USPSTF, which we're all familiar with, has given universal screening of all reproductive age women a grade B recommendation. The AAFP also recommends universal screening of all women of childbearing age. ACOG recommends screening all pregnant women, and the American Academy of Pediatrics also recommends screening all caregivers of children. Notably, the World Health Organization says that there is not adequate evidence for universal screening, and a 2015 Cochrane review, which preceded the systematic review done by the USPSTF, also found no evidence for screening. I put the asterisk next to the World Health Organization's recommendation because they do, however, recommend asking about IPV when assessing a clinical condition that's associated with IPV. And Neha touched on a few of these, but it's a pretty long list, but on it is depression, anxiety, PTSD, sleep disorders, unexplained chronic GI issues, unexplained chronic pain. The list goes on, but I feel like those conditions already are experienced by a majority of the patients that I see in clinic. So just a word about screening. One of the reasons that the data can be so hard to parse out is because screening, there's different types of screening. So for the most part, the data is about universal screening. So that's asking a standardized question to all women who are asymptomatic. There's also selective screening, which is screening only high-risk groups. We put that in quotes because I think Neha has already explained that this is so common that that starts to break down that designation of high risk. Routine inquiry is just asking without having a method or a protocol. And then case finding is asking questions if certain indicators are present. So even with all of those organizations recommending we screen, providers still struggle with even talking or asking about intimate partner violence. So majority of studies that have looked at how good we are at screening show that we only screen in about 10 to 20% of cases where it is recommended. And that even when patients present with injuries suspicious for IPV, only 45 to 80% are actually asked about it. So that's not even screening, that's case finding when someone is presenting with symptoms. We're not going to talk too much about screening tools. The main thing, we wanted to highlight just a few of them here. And mostly what we want you to take away from this is that there's lots of different tools. They're looking at different things. So it's important to know what you're using and if you choose to use one of these tools, and specifically like the time frame that you are looking at. So are you looking for present intimate partner violence or just intimate partner violence in the last year? The USPSTF has done, in their systematic review, they looked at 12 different screening tools, and all of them are, you can see the spread there of how accurate they are at identifying intimate partner violence, but there's pretty wide variation. And also some of these tools were tested in the emergency department, so that's also going to affect the sensitivity and specificity. We wanted to dive into the data a little bit, since I think screening is somewhat of a fraught issue. So looking at the systematic review that the USPSTF did for why they recommend their screening, they looked at a total of 30 studies. The total number of participants was almost 15,000, but these were very heterogeneous studies. So some of them were just looking at, can screening accurately identify women who have experienced intimate partner violence, and other studies were looking at, can they identify women and show a benefit due to some type of intervention. So only 2 of the randomized control trials actually looked to see if there are any harms associated with screening. And I think we're all happy to see that they found no harms associated with screening. There were only 3 studies, 3 randomized control trials that found a statistically significant improvement in outcomes with intervention. So one of them was a home visit intervention, and this was done for women in the prenatal period and then extended into the postpartum period. And the specific outcome they were looking at was experience of intimate partner violence. So did these women show a decrease in the violence that they experienced due to this intervention? And then 2 additional randomized controlled trials where we're looking at a counseling intervention, and they looked at they looked at rates of depression and then psychological violence and mild physical trauma. So those were the 3 fields in which they found a statistically significant benefit. So the limitations of this systematic review are that these studies were all so different, and the ways in which they decided to measure intimate partner violence and their outcomes varied widely. So it's really hard to sort of draw a conclusion from that. They also excluded any interventions that enrolled women who were referred based on symptoms or self-disclosure. So these are purely people who were screened positive and then put into the study. So we're leaving out a whole, a wide part of the population of people who are experiencing violence. And then finally, the evidence that the studies that demonstrated benefit were seen just in pregnant and postpartum women, and then they were extrapolated to all reproductive age women to get the group grade B recommendation that we have. So why is it so hard to show benefit of intervention for intimate partner violence? We wanted to, I think, the reason why, and we'll use the CDC's model of violence, is that this is a really complex issue. Unlike diabetes, I mean, we could all probably argue that diabetes is also complex, but this isn't just a disease. This is in many ways a social phenomenon as well. So pictured here is the CDC's ecological model for understanding violence. I'm going to superimpose one that we found from the Black Women's Blueprint, which is a anti-violence organization based out of New York, that I think actually sort of adds those 3 extra realms that are really important, I think, to our patients' experience of violence. So they added the structural realm, the historical realm, and the environmental one. I think anyone who's familiar with social determinants of health can understand how all of these things could play into someone's susceptibility to violence and their experience of violence. I'd like to especially call out the role of historical violence, particularly as it pertains to Native women. There has been, colonization has essentially disrupted whole cultures and populations, and really disrupted things that have made violence more of a problem in these communities. And I bring up this model because I think all of the randomized controlled trials included in the USPSTF systematic review are really just focused on the individual and aren't getting at any of these other things that are contributing to violence. And I would hypothesize that that's actually why it's really hard to show a significant benefit. What I also like about this particular model is this through line of the spiritual that you can see there. And I think one way of looking at this is seeing like how people are at risk for violence, but in the same, I think the reverse of that is that these are also where people find their strengths. So in relationships, in the community, from their history, and also with this through line of spirituality. So with all of that in mind, we do want to show or sort of showcase one population-specific intervention that I think really tries to address more than just the individual component of violence. This is a study that was done out of Canada, and it was built off a prior IPV intervention, but they basically changed the model to address specific needs of Indigenous survivors. So this study included 152 Indigenous women. It was a partnership between nurses and Indigenous elders, and the intervention was a weekly circle led by an Indigenous elder with health-related workshops integrated into that circle. There was also one-on-one health promotion work between the survivor and the nurse. It was a 6 to 8 month-long program. And notably, it was intended as a crossover cohort study, but none of the women that they recruited were willing to delay participation in the intervention. And we'll talk more about that in a second. So these are the outcomes of their study. They looked at quality of life, trauma symptoms, and they measured, and those are their primary outcomes. And then they also looked at secondary outcomes like depression, social support, and the rest are listed there. So they measured these at the pre-intervention, immediately post-intervention, and then at a 6-month follow-up. And almost across the board, there were significant improvements in all of these measures, with the exception of interpersonal agency and chronic pain. And generally, both the nurses who ran the study and the women who participated in the study found this to be an overall positive experience. Limitations of this, as I mentioned, were the inability to do a crossover design. There was a high attrition rate as well, which I think just highlights how many other challenges women who experience IPV are juggling in their life. And there were also high levels of support required by the nurses. So the majority of cost of this study was actually all patient-facing hours and time spent by the nurses to help remind people of their appointments and do a lot of one-on-one counseling. I put this link here at the bottom because the study authors actually did a small documentary. It's only about 20 to 30 minutes, interviewing both the survivors and nurses who were involved in these circles. And I think it's a really powerful way of talking about the results of the study in a way that these numbers can't even convey appropriately. So one of the strengths of that study, I think, is that it really took a trauma-informed approach to research. And so we're gonna take a minute here to talk about what trauma-informed care is. These are sort of the 4 key assumptions of an organization or study or clinic that is trauma-informed. So the first is that I think we can use the example of this study. They realize the widespread impact of trauma and they understand potential paths for recovery. They recognize the signs and symptoms of trauma. An example of that might be like hypervigilance, sort of a inability to maintain long-term relationships, things that we sometimes code as non-compliance are really signs and symptoms of trauma. And then another assumption is that a trauma-informed organization responds to trauma by fully integrating knowledge about trauma into policies, procedures, and practices. And I think most important, particularly for those of us who work in the healthcare setting, is to actively resist re-traumatization. So understanding that certain things that we take for granted in the clinical setting may actually be re-traumatizing for folks. And just to think about that study, I think they recognized the importance of allowing women to all be in the treatment arm, even though that is sort of counter to how we think of the way we think evidence-based research should be done. We're going to talk about the 6 principles of trauma-informed care, but I'd like to take this moment to talk about our transition at this point in the talk from sort of randomized controlled trials, what we would call evidence-based medicine, into what I think we're going to call practice-based medicine. So even if we don't have studies that can show a statistically significant benefit of intervention, there are years and years of practical knowledge that people who have worked with survivors for years have gained and know to be helpful. Specifically, Neha and I talked to the people in our clinic who do this work every day. At Carolyn Downs, Monica Lake is a maternal health counselor, and at the Seattle Indian Health Board, Stephanie Cassidy is the gender-based violence program manager. And both of them were really generous with their time and talked with us about how our individual clinics support survivors. So we're going to make a shift here. There's still data, I promise, and evidence, but we are going to make a shift to talk about the ways in which the folks in our clinic support survivors and how it maps onto these principles of trauma-informed care. So first is safety. So that means making a physical space that feels safe and welcoming. The other is trustworthiness and transparency. I think both Monica and Stephanie talked about how important it is to cultivate a trusting relationship with survivors. This also means having clear roles and policies. At the Seattle Indian Health Board, before a survivor enrolls in our services, they make it very clear kind of what they have to report, what they won't report, what confidentiality rules are, so that's all up front for everyone to understand. Peer support is a huge piece of this, and I think both of our groups either refer to external peer support groups or have in-house support groups. Collaboration and mutuality is an idea of team-based approach and leveling of a power differential, both between provider and survivor, but also among staff. So recognizing that everyone has the ability and role to be therapeutic, even if they are not trained as a counselor. And then empowerment, voice, and choice is the idea that healing is survivor-led, and they are the best people to identify what their needs are. And staff is more of a supportive role in facilitating their healing. An example that Stephanie gave at the Seattle Indian Health Board is that she may have an idea for what a survivor should do to heal or to leave a relationship, but the survivor is the person who says, you know what I really need is housing, or what I really need is food. And so the advocates help them meet that need and sort of let them guide their recovery. And then finally, cultural, historical, and gender issues. The idea is that a trauma-informed care organization or trauma-informed care recognizes the role of all of these things, and also how they can be a source of resiliency as well. Okay. I wanted to take a minute here just to talk about one of the things I love about trauma-informed care is that I think we are always thinking about how can we provide trauma-informed care to the patient, but trauma-informed care encompasses staff as well and caregivers. So it isn't just a one-way thing of us giving to them, but it's a kind of entire environment that supports everyone involved. So on the practice level, so this means sort of at your clinic level, we extend that same recognition that trauma is common and that staff are not exempt. Providers also can experience trauma, and maybe bringing that to work as well. So it's not just our patients who are struggling with the effects of trauma, but also ourselves and our colleagues. The other thing that it recognizes is that there's a risk of vicarious trauma. Even if you wouldn't identify yourself as having experienced trauma, constantly hearing these stories and showing up for our patients is traumatic in and of itself. And the idea is that there should be supportive responses for staff as well as for patients. So that might mean a chance to debrief, to have an interdisciplinary team meeting, to allow opportunities for self-care, and then also provide the same types of therapeutic resources that we would provide for patients. And then on a personal level, I think one of the reasons why it's so hard to talk about trauma is because it feels like, well, I'm not ready to do that. And it can be really triggering to get into these really intense conversations. So I wanted to highlight these 4 C's that one of my mentors from med school who does trauma-informed care all the time shared with me. And one is to be calm. So you being calm and grounded in an interaction with someone who has experienced trauma is actually really helpful and emotionally regulating for the patient. The other thing is to contain the interaction. So you do not need to go into every single detail of the traumatic experience that person had. You should do what's emotionally manageable for both you and the patient. Finally, care for the patient and yourself. And then I think focusing on coping is the last thing. So just highlighting all the ways in which that person is resilient and strong.
Okay, so we know that we should be asking about this in clinic or in the hospital, and what makes it hard to do that, or what have providers identified as barriers to even asking about intimate partner violence? So this was a study done that looked at what these barriers are, and they found that providers perceive like a lack of effective interventions for IPV patients, and a lot of that is kind of what Kara has already talked about. They have a fear of offending patients. They feel like there's a lack of provider education about intimate partner violence and limited time to conduct screening. And we'll hopefully address some of these to make these barriers overcomable for our group.
I forgot I was talking about this slide. So I promised there would be more data. Here's some more data. So these are the results from a qualitative study from 2005 that address specifically all those things that providers say they're worried about. So survivors, it was a qualitative study in which survivors were asked what advice they would give to healthcare providers when talking about intimate partner violence. And when they coded all the data that they got from these conversations, they were able to pull out these 3 themes. The first is to give a reason for asking. All of the women cited the importance of having a personal connection with the provider, and they also really liked that when inquiry was normalized as part of the medical history. Like, this is just part of what I ask about when I'm assessing your health. The other was to create an atmosphere of safety and support. They highlighted the importance of not asking when partners are present, of not asking questions about this when patients are in vulnerable positions, so like in a gown or in a state of undress or in a physically uncomfortable position. And they also really liked the presence of in-office posters and educational materials, because for them that was a sign that this was a safe thing to talk about. All of them also mentioned the importance of providing resources regardless of disclosure. They ask that providers be patient, open, and supportive when patients aren't ready or unwilling to disclose. And a lot of them also wanted other avenues of receiving information. So not just from the provider, but maybe out in the lobby or having access to other sources of information.
Okay, so we've heard what survivors are really looking for from their providers. And so we are kind of using that to kind of help argue that we should really be moving from universal screening to an environment of universal education in our clinic. That universal education is actually the way to do trauma-informed care for IPV. And I will talk about a few different ways that we can incorporate universal education into our clinics. Okay, so one model to do universal education is called CUES. It is developed from this Futures Without Violence organization and website, and all of the materials are free and on their website that I'll kind of be talking about. There's also a telehealth version to CUES as well. So CUES uses a lot of kind of physical materials, but there is a telehealth version on their website. And I will kind of walk through how this is kind of a trauma-informed approach. So starting with C, C is confidentiality. So as Kara said, survivors really want to make sure that it's safe. It's a safe place for them to discuss IPV. And so, you always want to see the patient alone for a part of every visit so you can bring up something like relationship violence safety. A lot of clinics have implemented kind of a blanket policy on seeing all patients individually to start the visit as a way to kind of create this environment. Also, it's really important to know and share any limits of confidentiality with your patients, and we will talk about what that means in Washington State later in the presentation. Okay, so then moving to the UE in CUES, Universal Education and Empowerment. Now, the way that the CUES model really incorporates this is by use of safety cards. And this is their way to include universal education into the clinic. And it's their model and tool. Their recommendation is to give each patient 2 safety cards to start the conversation about relationships and how they affect health. Now, this is not necessarily what you would have to do in your clinic. There's many, many ways to incorporate universal education into your clinic and to use these materials. Even having them available in the bathroom, hanging them up, there's posters, all of this kind of stuff can be a step towards incorporating this into your clinic. And there's just many ways. So I'm going to review 2 different safety cards. There's many others on their website that are all really great. So this one is, did you know your relationship affects your health? And so these cards are fold up to kind of be the size of a business card. They're kind of meant to be discreet, that somebody can keep in their wallet or hand out to a friend as well. And some of the questions like on this card in particular is like, is my partner willing to communicate openly when there are problems? Does my partner give me space to spend time with other people? And on every card, there are resources as well. And on the cards, there are like these national resources, which can then help patients find local resources. This is another card that is specific to our Native population. It really, again, is culturally embedded in that community, which is so important. There's also cards specific for the LGBTQ population, for adolescents. And this one is really focusing on like the sacredness of your body and feeling like you have agency to make decisions that are best for you. Again, and it again has resources on there. The way that CUES introduces these cards is they say like, we're giving this to every patient, and you can take time to look at these questions if they are bringing something up for yourself or for somebody that you know, and that way you have a resource to kind of help them as well. And then the last part of CUES is S, so support. So through a trauma-informed lens, disclosure of violence is not at all the goal, but it will happen. This is so common. And so you really need to know in your role how to support somebody that discloses a history or current intimate partner violence that they're experiencing. And so knowing how to make a warm referral or warm handoff to a local resource, whether that's in your clinic specifically or a local community-based organization or a national hotline, is really important. And we will go through some of these resources as well. Okay, so what is, how is this CUES model kind of playing out in practice? They're still kind of in the pilot stages of gathering evidence for this model, but this is a study that has been done from one community health center in Oregon, an FQHC, that has incorporated CUES, as well as a referral to a local domestic violence community-based IPV advocate. And when they incorporated CUES, they found that 39% of their patients reported that they told their healthcare provider about experiencing an unhealthy relationship, right? This is almost exactly the 1 in 3 that we're seeing statistically in our country. 55% of patients reported that they had experienced an unhealthy relationship or had been harmed by a sexual partner in the past. 68% reported they were likely or very likely to share the information with somebody that they knew. And 69% thought it was really helpful to kind of talk about this in a clinical setting. And this graph below shows what kind of services were provided to survivors over the 6 months. So again, this is survivor-led. What resources did they find helpful and did they want to access? So legal advocacy, food insecurity, housing, safety planning, mental health resources. It's a very diverse list of different services provided. Okay, so that's one way you can talk about this in your clinic with free resources and ability to get those cards. How else can you discuss relationship safety? I got this resource from Monica Lake, our maternal health counselor at Carolyn Downs, and this is a website, loveisrespect.org. And I would really encourage everybody to go to this website. It's both helpful for you and probably for somebody in your life and for your patients. It is initially formed for adolescents, but I think it can be really helpful for everybody. And it goes through different types of healthy and unhealthy relationships. And it kind of talks about different types of relationships. You can see some screenshots here from their website. And they also have a healthy relationship quiz that you can direct your patients to take on their own time to kind of just like in an annual visit, kind of just think about if they're in a healthy relationship and what that means. This is another tool that Monica uses a lot to kind of walk people through what is a healthy relationship. Oftentimes, this is not something that is, it's very difficult to talk about in different cultures, and that this equality wheel is kind of the opposite of the power and control wheel, and it can show different aspects of a healthy relationship. It can both be used to identify what are positive aspects of a relationship that you are in, or what do you deserve, and can kind of also help initiate this conversation in your clinic. Okay, so now that we know kind of how to even initiate this conversation, what do you do if there is a positive screen or disclosure? And we're going to kind of talk about this in three different steps. So 1, assessing risk, planning a safety response, and identifying resources. We recognize that most likely you will be doing this in conjunction with somebody in your clinic, a behavioral health staff member or a social worker, but we also want you to feel prepared and aware of what happens in these next steps in case you have to do this alone. So a patient makes a disclosure that they're experiencing intimate partner violence. You want to identify what kind of risks they're experiencing. Survivors are really, really good judges about the risks they face, and you should trust their concern about certain situations more than your instinct about them. Something that may not feel like a red flag to you, but feels dangerous to them, you should still take that at their value. So there's 2 types of risks, right? There's risks focused on the abuser, and these are things like, are there firearms in the house? Have they made threats? Because those can actually be really good indicators as to what might happen. Have they threatened to commit suicide? Have they threatened to kill the patient? And what kind of immediacy is the survivor feeling like these risks are to them? That will really judge the focus of your safety planning. Also acknowledging there are life risks outside of the abuser themselves. So family members, their cultural faith community, their immigration status, the legal system, criminal justice system. These are really important to kind of work through as well or be aware of. But again, focusing on the abuser risk are kind of like what your role will be in the clinic setting.
And one of the questions that I think comes up a lot is, I've received this disclosure, or I suspect intimate partner violence. Do I have to report it? And this was actually a surprise to both Neha and I, because we did med school in other states where intimate partner violence is part of your mandated reporting responsibilities. But what is highlighted here is that in the state of Washington, these are the only situations in which you need to report suspicion or evidence of abuse or neglect. So when it involves children or when it involves a vulnerable adult. I think we can all imagine the situation in which a survivor comes to you and they have children at home. And so that can be kind of a gray area of, do I need to report potential neglect of this child? And it is specifically stated in the laws in Washington that exposure to domestic violence that is not perpetrated against the child does not constitute negligent treatment in and of itself. I think we can all appreciate that that is still vicarious trauma, and that is going to have health impacts for that child, but it is not something that you are legally obligated to report. Sometimes, however, a survivor will want to make a report, and they get to choose. So an adult who is not a quote unquote vulnerable adult gets to decide if they file a police report. So if they do want to make a report, important things that you can do to support them are to assess the need for immediate danger and retaliation, and really maximize the role of the patient in the reporting process. This can be a really empowering moment for survivors. And so everything you can do to sort of give them that agency is going to be helpful. The other thing you can do is ask if they're willing to call or meet with an advocate to develop a safety plan in case of retaliation. And the advocates in my clinic, at least, will also help a patient go through the online process of making a report if that's something they want to do. And the reason, I know sometimes it can feel like, oh, we're minimizing the violence someone has experienced by saying you don't have to report it. The reason that that's important is because confidentiality is key. And if you aren't legally obligated to break that confidentiality, you shouldn't do it. And then also a lot of the people that we see in clinic, I think, have also experienced trauma at the hands of the criminal justice system. And currently a lot of the policies in place to support survivors is a specifically legal criminal justice focus. And so recognizing that for some of our marginalized communities, that is actually not going to be a path of empowerment or agency for them. Finally, what you can always do, and kind of what our counselors have asked us to do as clinicians, is to document. We're very good at documenting. So if there is any knowledge of a weapon or any threats made by a partner, include that in your charting. Always document injuries. If the patient and your EHR allows, pictures are always helpful. Anytime you can use direct quotes, that is also helpful. So those are the things that you can do as a clinician, regardless of whether the survivor is ready or interested in making a report.
So now we're moving on to the second part of what you do after a positive disclosure or screen. Safety planning. This is, they say, use this as a verb, not as a noun, recognizing that it's an active, ongoing process, not just a one-time, one and done kind of thing. It's survivor driven. So whatever, this safety planning can also be done to attempt safety within the relationship, or if they want to leave the relationship, right? So wherever they're at, you're meeting them where they're at and helping them feel safe in their relationship. If they don't have current safety concerns, but one question that can be helpful, if they do have concerns for their safety in the future, what would they do? So you can kind of talk them through. Would they call 911? Would they call an IPV helpline? Do they know that those exist and what they are? Would they try to leave? who would they seek help from? And you can often advise them to keep their important documents and some money in a safe place in case that moment arises. This is also a great time to kind of introduce the idea of a warm handoff. So you can start the beginning steps of safety planning in your clinic, but again, our time is limited. So you can say, if you are comfortable with this idea, I would like to connect you with a DP or a DV or IPV advocate at our local organization or at the Seattle Indian Health Board. They have that resource right in-house to review with you what resources and supports they can offer you. So what is an IPV advocate? Like if you're planning to refer patients to them, what could they provide? So this is a different resource outside just kind of like your mental health providers at your clinic. They have specialized training in intimate partner violence. Okay, this is free for clients. There's often shorter wait times to kind of get in the door in these organizations, and they have access to other services, housing, emergency funds, support groups, counseling. They can also, like Kara said, walk survivors through the reporting process if they choose this option. They can accompany them to court, they can connect them to legal representation. And a lot of these organizations are really rooted in the community and can offer culturally responsive services in the patient's primary language. Again, like we said, this is not like a one and done thing, safety planning, or even this whole topic with patients. So follow-up care is vital and essential and should be offered after disclosure of current or past abuse. So you want to make sure that you have a number or address that is safe to reach the patient, making sure that, do they prefer certain days or hours when we can reach them at home? I have a patient that I only can call certain times of the day. We schedule our appointments and she goes on a walk during our appointment on the phone because she can't do it in the house with her partner present. Is it safe for us to make an appointment reminder call, right? So again, trauma-informed care, we're not aiming to re-traumatize. So really making sure you set up a safe follow-up plan. And if the patient does not disclose current or past IPV, again, this is not the goal. You want to document that the assessment was conducted and that the patient did not disclose abuse. But if you suspect abuse, document your reasons for concern, right? Physical exam presents with indicators for violence. This can be helpful in the future if the survivor does end up wanting to make a report. You will have it documented already and can provide that support to them. Okay. So what are some of these local resources, right? We hate asking about things if we feel like we have nothing to offer. And these are local resources that have been vetted and recommended by our local community clinics. At Carolyn Downs, they often use LifeWire, Dawn, and Consejo to refer patients to. These all have IPV advocates. Dawn and LifeWire have a 24-hour hotline. They have emergency shelter. They have fund support, legal advocacy. And these are local in Seattle based, right? So these are great places to direct patients to. Consejo is rooted in the Latinx community. They also have one-on-one DV or IPV advocates there. I just want to highlight another organization, API Chaya. This is focused on our South Asian and immigrant population. They have advocates that speak multiple South Asian languages and can be a really helpful resource for that community in Seattle.
And then our gender-based violence advocates, in addition to using the resources that Neha just mentioned, have also added to this list the Jewish Family Services organization in Seattle. They found this to be a very responsive group that also has a food bank, which may, like we've talked about, may be the main concern or need that a survivor is identifying. New Beginnings is another group that's local that has shelter availability. Mother Nation is a Native organization in the community that works, does violence prevention work, also helps with housing, and is also working on anti-trafficking programs as well. And then I think one important thing is I really respect that our DV advocates at the Seattle Indian Health Board recognize that currently we're not really well equipped to support our LGBTQ and Two-Spirit survivors. And so they recommended Pure Seattle as a group in Seattle that's doing a much better job, I think, of supporting those survivors. On the national level, there are lots of hotlines that can be accessed. The National Domestic Violence Hotline is the number that is on all of those safety cards that Neha talked about. There's also a dating abuse helpline and a sexual assault hotline that can be used. We wanted to highlight the Strong Hearts Helpline, which is a Native organization that is staffed by Native counselors, and they have a 24-hour crisis line that you can call, and also an online confidential chat if people prefer to do a texting thing. So we've gone through a lot of resources. We've talked about trauma-informed care. We felt like it was actually really appropriate to sort of close with the recent results of this UIHI report. That's the Urban Indian Health Institute, which is the research institute that's housed within the Seattle Indian Health Board. This report was published just earlier this month, and is the result of a grant opportunity that they extended to Native femme-identifying survivors of sexual assault who were impacted by the COVID-19 pandemic. So this was funded by the CDC. It involved 121 participants. And the way it worked was essentially a grant opportunity. So femme-identifying Native survivors received a $400 grant once they did the application process. And what they had to do was basically identify what their greatest needs were, like what would the money go towards. There were no restrictions on what this could be. We were mostly just trying to, I think in the trauma-informed approach, they were saying, you know what you need, just tell us what it is. And then they were given a platform for sharing their stories. So they were given 2 open-ended questions to answer. One was, what have been the resources in your community outside of law enforcement that have assisted in your healing as a survivor? And then the second question was, what resources would you like to see more of in your environment in order to assist you in healing as a survivor? So they identified their greatest needs and sort of what they would apply the money to as self-care, mental health, utilities, food access, and housing. The existing healing resources, so again, sort of like with all qualitative data, this was categorized and codified to get these themes. So the existing healing resources were traditional culture and medicine, a sense of community, survivor support groups, helping others, physical activity, and knowledge and learning. And a lot of them cited that actually providing this information through this grant opportunity gave them a sense of helping others. So sharing their story to help lift other survivors up. And then what they recommended for the future, what would help them, was cultural safety and care, which I want to explain what that is. Cultural safety allows for a shift in the power relationships of patient-provider interactions and affirms that patients have autonomy over their own care plans and well-being. So this was something that they highlighted as something that they wanted to see more of to help their healing. The other was the safe space, and then community education and awareness, and access to affordable care. The paper does a really nice job of weaving in all of these stories to create a really beautiful narrative. So I am pulling out these 4 quotations that fit into each of those 4 categories for forward growth and movement. So for the first one about cultural safety, we need people who can navigate us through a system that is broken for sexual assault victims. Telling our story 50 times before we are taken seriously is traumatizing. Every urban area needs a place for women to gather safely where their children are also welcome. And then I would like to see more professionals who specialize in trauma-informed care and take state insurance or have grants that can help pay for therapy. And then finally, I think intercepting trauma and offering healing to the younger population is vital, because then the problem is addressed before other and even more serious problems can result. And I really encourage you to read the entire report to get an even more kind of full picture of this. So finally, we wanted to just leave you with some take homes. It was a lot of information, but I think even with just these things, you'll feel better equipped to address this in your own clinical practice. So reminders not to make disclosure your end goal, Don't make referrals without a survivor's consent, and don't make assumptions about what the survivor needs. We ask that you do assess for immediate safety, do document injuries, do follow the lead of the survivor, and do partner with local organizations. Do you want to do the
Sure. We'd just like to thank Monica Lake and Stephanie Cassidy, two kind of local experts that have been doing this work for years in both our clinic communities. Dr. Barry Saver for all his advice, and really, I mean, it's our patients and relatives for trusting us with their stories.
These are all of our references. And any questions? I'll stop sharing.
Yes, it was found.
Okay. Alice asks, for the Canadian study, how is quality of life measured? It was all done by survey. So these were survey questions. And then for high attrition rate, yes, they did address that. And usually it was other stressors in life, you know, childcare, having to work a job, having transportation issues. So all of those things interfered with people's ability to make it into the study. One other interesting thing, or not interesting, sort of more tragic, is just that the amount of effort that the nurses had to do to help people make their appointments, I think is the consequence of trauma. So a lot of, I think half the women had sustained head injuries in the past, and over half said that they had memory problems. And so you can imagine that these are women who are going to need a lot more support to make appointments and come in for regular visits.
Devesh says, Chaya was co-founded by Dr. Thamit Sethi. Yes, it was. She started the organization literally like just as a helpline with some friends, that has grown into this amazing, robust organization for the South Asian community. Again, just like very trauma-informed example of a community-based organization responding to the community needs.
Okay. And we had another question about how do you personally incorporate IPV screening into your everyday practice? So my clinic does not currently have a universal screening protocol. I know that our gender-based violence team is working on that currently. I think Neha and I talked about this, is that with our patients or with our relatives, I think creating a sense of just openness and sharing. So when I'm asking about relationships, I also just make that a time to be like, tell me about your relationship, or how are you feeling safe in that relationship? Like, what are the positive things about that relationship? And I think the hard part, I think, because we always want to do something as clinicians, is to recognize the importance of patience, and also that disclosure may not happen for several visits, and that ultimately that's not the goal. Like, you can provide resources for survivors without even really knowing that they, or without confirming that they have experienced violence. I have a young relative that I'm taking care of who has alluded to violence in her past, and I haven't asked for details because she doesn't feel, it's clear that she doesn't feel comfortable sharing that yet, and I don't really need it. I can just sort of take a trauma-informed approach and sort of make my efforts not to re-traumatize, and to offer her resources whenever I'm able to. Are specifically trained IPV advocates exclusively? Oh no, I lost a question.
I think I got it. Yes, all of those local organizations have IPV advocates. It's part of their organization. Seattle Indian Health Board is, like, I think the only clinic that I know that has IPV advocates at their clinic, but all of these local organizations have that role. Just making sure we addressed your question. We, at our clinic, so Monica Lake is on our behavioral health team. She does a ton of work in IPV, but she's not an IPV advocate. So she also refers out for some of these more kind of targeted and specific support services.
And Tiff, I think a lot of it also just comes down to like how much bandwidth all those folks have, right? A lot of times we're referring out to people who just focus on that because our behavioral health providers are completely overtaxed.
Thank you all so much for listening.
Yes, Tiff. The caps were necessary.
Thank you all.
Thank you.